practicing pediatric psychologist with a PhD in cognitive psychology from Princeton and postdoctoral work at Harvard. Really originally focused on language acquisition and processing, but really curious to hear about the TPEF work that you're going to talk to us today. And I'll get out of your way now and let you take over.
Thank you so much for the introduction. It's a great privilege to be here, and I'm going to share my screen. Okay, I hope everybody can see it. So thank you to the Brain Foundation for inviting us to speak. I'm speaking today here on behalf of Jellicoe Light. I'll be talking about our first clinical trial that we have just completed. And before I move on to the presentation, I just want to give credit to people who deserve it. These are our co-authors, our scientific advisors, people without whom this research wouldn't be possible. Special thanks to Dr. Fratkin, who is a pediatric psychiatrist and who acted as a PI on this clinical trial. Many thanks to Professor Nazer, who shared her wisdom with us in the most generous way. Without all these people, this research wouldn't be possible. So with that, I'll just move on. I have to say, I'm so lucky to present the last. I feel like I can skip through many slides of the introduction or give just really high level of introduction. What is transcranial photobiomodulation? In some ways, like transcranial magnetic stimulation that was described before me, it's a way to stimulate the brain. This is what Professor Navier called optodynamic therapy, and maybe it's the most accurate name for this technology, but basically it's a non-invasive treatment and it stimulates brain transcranially with near infrared light. In our trial, it was pulsed near infrared light. Now, what happens when near infrared light reaches the brain? It's being absorbed by the cells. Specifically, it activates mitochondria, and there were so many excellent presentations, amazing presentations at this conference that showed intimate connection between mitochondria and autism. Basically, there is almost always some kind of mitochondria dysfunction, if not a full-blown disease or disorder and dysfunction present, which is underlying autism. So with this stimulation, we activate mitochondria to produce more ATP, which results in brain healing itself, like was so profoundly said before. Body, brain wants to heal, and with a little bit of help, it will. It promotes synaptogenesis, it promotes neurogenesis, and it reduces brain inflammation. Oh, it also, like I said, it promotes synaptogenesis, so it increases brain connectivity, which is one of the underlying causes of autism. This technology has been studied in many studies that looked at dementia, stroke, traumatic brain injury, and depression. And it has been shown to be extremely helpful. For example, in aphasic patients who suffer from stroke, it has helped with language production. It also has been shown to be helpful with memory, mood, sleep. Why autism? It's actually, I feel that this technology was intended for autism, always. First of all, it improves functional brain connectivity, and I'm very thankful to NeuroWave, who talked about connectivity before me, so I don't have to go again and explain what it is. It also affects brain oscillations, and again, just like presenters before me, I'll be talking about brain waves as one of the possible biomarkers of autism. Why look at kids with this technology? I think, again, this technology is suited for children because the skull is not thick. I think it's about 3-4 millimeters thick only in young children. So the penetration of the light is not an issue. There is a lot of synaptogenesis still happening because the children are so young. There is neuroplasticity. Again, with a little bit of help with brain stimulation, the brain will heal, and the connections that need to form will form. So I think this brings us specifically to our clinical study. I just want to show you a little bit of the data. I believe it was already presented yesterday by Professor Siranoglu, but still, this is a study that used this technology, transcranial photobiomodulation, in 2018. Dr. Leisman and his colleagues used stimulated occipital lobe with near-infrared light, and by week 4, they found a major drop in symptoms as measured by clinical global impression severity scale. And this reduction in symptoms sustained until week 8, which was the end of the trial. By the way, they did a follow-up. They followed these children, and children were from 5 to 18 years old. They followed them 6 months later, and the gains that were made during this trial remained. So children who improved continued improving. This is a study that was done in Massachusetts General Hospital with adult participants by Professor Siranoglu and Professor Kasanam. They also used transcranial photobiomodulation. They stimulated different brain areas. I believe they stimulated F1 and F2. And they also measured improvement with clinical global impression severity scale. There is no control condition in this study, but it produced very hopeful results with adults in that the symptoms did decrease by the end of the study. So by the midpoint, which was week 4, there was initial significant decrease, and it continued by the week 8. So we do have some preliminary data, and now we wanted to look at EEG specifically. Why EEG? Why is this endpoint so interesting? For autism, the importance of EEG has been already discussed before us, so I could drop that slide. But for transcranial photobiomodulation, there was a study reported in 2019 by Zamarodi and colleagues. They looked at healthy adults, and they applied transcranial photobiomodulation for 20 minutes only. And after this single application, they detected the reduction of slow frequency waves, which, because these were healthy adults, the slowest frequency was theta waves, and they detected statistically significant reduction in theta waves. So from that alone, we knew that brain waves are receptive to this, sensitive to this kind of stimulation. We could look at them. And so that brings us, without further ado, to our first clinical trial that we have conducted. I'm extremely proud. Our company, Jellicoe Light, has conducted the first FDA-regulated clinical trial on this technology. It's an IRB-approved trial. We recruited children 2 to 6 years old, and the study was conducted in clinics in Brooklyn and Manhattan, and we did our best to recruit children from diverse background. We recruited male or female participants between years 2 to 6 years of age. We really closed. We received so many calls. Parents are so desperate from 8 and 9 years old, and we said, no, we're stopping at 6. This is our first study, and we really want to get into that critical window for language learning, because we want to see what this way of neurostimulation does, what it does, how it affects language learning. All our participants have been already diagnosed by moderate or severe autism spectrum disorder, not by us, by a licensed professional. And we allowed all participants to continue receiving the therapy. If somebody was receiving ABA, of course, please do. Our only request was not to start it during the course of the trial. So whatever you have been doing before the trial, go ahead. Please wait for 2 months until this is over to start something else, because we really didn't want any confounding variables. We had an inclusion criteria, and the main one, we excluded kids with epilepsy. That was really the main. I think we had to exclude one child because of that. She was on anticonvulsant medications, and we decided to be careful. It's the first study. Even though this treatment is extremely safe, we wanted to be safe. So we had 2 main objectives. One is to demonstrate that optodynamic therapy, I really like this new name, or transcranial photobiomodulation, it's an effective treatment modality for improving symptoms of autism in children. And secondly, we wanted to validate EEG as a valid measurement of the effect of TPBM and a valid biomarker of autism. Let me just check. So before the treatment, before kids started receiving any treatment, we conducted childhood autism rating scales for placebo and active conditions, of course. And then after they finished 8-week trial, we did those rating scales again for placebo and active conditions. We collected 64-channel medical grade EEG, and we also conducted weekly parental interviews. So we called the parents and asked how your kids are doing. We also talked to the therapist once toward the end of the study, and that was also phenomenal. I'll talk about it later. So it was a randomized, double-blind, placebo-controlled study. On this picture, you see a little boy. His name is Anthony. He was one of the oldest participants. He was the most, if not the most, one of the most severe kids. He's completely nonverbal. He was brought to this trial by his father, who was crying, literally crying, because they couldn't handle it anymore. They were afraid that their landlord will kick them out of the apartment because the boy was jumping, and he was a large child. He was jumping up and down, screaming, yelling. Even when he was happy and not upset, he still had to jump to stimulate himself. And he was making really loud and disturbing sounds. And so the parents really didn't know what to do with this child. So he is wearing our device. You can see him. The device is very comfortable. We're very proud of it, because one of the issues that everybody brought up is these kids are sensory. How are you going to charm them into wearing this device? Turns out it wasn't a problem. It was so soft. The material that covers all the electronics is really soft and smooth, and children loved it. And actually they kind of love being snuggled. So many of them even enjoyed it. So the device uses LED, so near-infrared light is being delivered through LED, and it stimulates very targeted brain areas. Specifically, we stimulate occipital lobe, we stimulate prefrontal cortex, we stimulate Broca areas, left angular gyrus, and some points on the default mode network. And we can talk about it later, maybe offline, why we believe it's important to stimulate those areas. But again, this is not a helmet that just shoots lights into your entire head. That would be the wrong thing to do. And after many discussions with our advisors, we figured out the specific points that need to be stimulated. It's infrared light, so the wavelength is 850 nanometers, and we used pulsing, 40 Hertz pulsing. So a little bit about our sample. 30 kids were recruited, were enrolled. 23 boys, 7 girls. We couldn't get equal number of participants, boys and girls, because this is just the nature of the disease. This condition affects boys more than it affects girls. And we really wanted to proceed with the trial rather than wait until we match them by gender. The average age was 4.5 years old. We did have older kids, 6 years old, and we did have younger kids, 2-year-olds. Complexion is important for this technology because darker skin just absorbs more light, and some of our darker participants weren't. At some point, I was worried that did we get all African American kids into the placebo condition? Nobody's responding. What's going on? By week 7 or 6, suddenly parents of kids with darker skin started saying, "Oh, I see a big difference." And this is because dark skin absorbs light, and when we think about dosage, this needs to be taken into account. We had 63% of our kids had some language. They again, these are moderate to severe kids. Some language doesn't mean functional language. They were echolalic. They couldn't express what they need, but they did have some language. And 37% were nonverbal. 43% received ABA. And 34% received something else, speech therapy, some kind of therapy, and 23% received nothing. This really broke my heart because these are moderate to severe kids in New York City, where therapy is really available, but still, for some people, it's more expensive. Some people didn't have time to bring the kid to the therapist. Some people didn't receive therapy through channels like Department of Education, they weren't approved. And so even for these severe kids, 23% of them were left with nothing, which is really, really sad. I just wanted to show, this is the demographics between groups. The main point here is that there is no statistical statistically significant difference in the distribution between the groups. So we did have 5 girls in the placebo. Out of 7, 5 of them were in placebo condition and 2 inactive. With only 30 participants, this difference wasn't statistically significant. We were lucky with age. Active condition was 4 and 7 months and placebo condition 4 and 5 months. We were very lucky with therapy. It turns out 12 participants in active condition received some kind of therapy and 11 in placebo. So the groups were really well matched. I just want to point out that we had slightly more nonverbal kids. 7 nonverbal kids happened to be in active condition and 4 nonverbal kids happened to be in placebo condition. This difference also wasn't statistically significant, but it could be important. So the exciting slide, the results. Childhood autism rating scale. So this is, for those who don't know, this is the behavior. There are scales that measure eye contact, scales that measure response to name, response to commands, usage of language, usage of body, usage of toys, ability to play with toys, ability to interact with others. This is standardized scales that have been used in clinical practice for many years. This is well-validated method to diagnose autism and measure severity of autism. And that's why we selected it, because it's able to measure the severity of autism. And you can see statistically significant drop in the severity of symptoms for these children only in active condition. So if you look at the bottom chart on the bottom, you'll see that about 9-point drop was for active condition, and FDA considers 4-point drop to be clinically significant. So here we have more than twice as much. For placebo, we did have some placebo effect. About 2-point drop was placebo condition. So this is a huge change in behavioral symptoms. Oh, this is a fun slide. We talked to parents. Every week we called parents and we asked the same, not us, our research assistants who were blinded to the experimental condition. The parents were blinded to the experimental conditions. The blinding was done really well. So those assistants, we're forever thankful to them, called the parents and said, how is Anthony doing? How is Camila doing? They asked about eye contact, they asked about concentration, communication, any improvements in behavior. They also asked about side effects, headaches, tics, self-injurious behaviors. So first of all, every study, I'm convinced now, should have a placebo condition, because parents are extremely hopeful and parents really want to see improvement. And there is a lot of energy when you enroll your child in a trial. There is a lot of energy around them. You spend more time at the time, you interact more at the time, and that's great. However, to evaluate the effect of the treatment, we really need placebo control. And we did have significant difference even in parental interviews. We did have placebo effect clearly, but p-value was exactly at 0.05, which is statistically significant. And parents of participants in active condition reported those positive events more frequently. So this is simple counting, and it was non-parametric statistics. I believe it was Wilcoxon test. For side effects, there was no difference between conditions. So again, at least for the 8 weeks, for the duration of the trial, this is a very safe treatment. Nothing happened to the participants of active condition that was statistically or clinically different from the participants in placebo conditions. We did have a couple of kids who became more active or a little bit overactive, and that resolved spontaneously after a couple of days. Now moving on to EEG. So we looked at the intensity of delta wave. Remember the slide I showed in the beginning of the presentation that showed EEG data from Zamarodi? They found reduction of the intensity of slow waves because they used healthy adults. The slow waves was theta waves. Here we looked at delta waves, and I have to say that the very presence of delta waves in wakeful state is a sign of neurological condition. It shouldn't be there. These are deep sleep waves, unless the brain is inflamed, unless something is happening to the brain. I'll talk about it later, but for now, I just want you to look at the top chart on the top. And the line of best fit for the active condition is orange, and it shows negative slope. As these kids participate in the study, the intensity of the delta waves drops down. However, nothing like that happened to kids in placebo condition. Now, I want you to look at the chart on the bottom, and this is my favorite finding. I'm so excited. We correlated the change in delta waves with the change in cars. So the y-axis shows you change in cars, and 0 is the midpoint. For some kids got worse and their score went up. Some kids improved and their cars dropped down. And the x-axis is the change in delta. So if you look at the bottom left corner, these are the kids who are doing the best. Their cars is low and their delta waves is low, and you see majority of kids here are red, which is active condition. And if you look here, you see kids with high presence of delta waves and high car scores. This correlation was hugely significant. R squared is 0.64, and p-value is extremely small. What did we just do? We validated, first of all, both our measures, right? We found intermeasure validity, which is hugely important. We also validated delta waves as a potentially biomarker of autism, because again, when there is something off with the brain and it correlates with the behavior, the intensity of delta wave is higher. When did this change in delta wave happen? Again, the presentation before me talked about also change in EEG and brainwaves, and I think, if I'm not mistaken, they mentioned by week 2, by 14th day. We found the same here. By day 14, again, the red chart represents the intensity of the red line represents the intensity of delta waves. We see statistically significant drop. Nothing happened, obviously, to placebo condition. And what's interesting is that the behavior changed by week 3 or 4. So when we analyzed the data, we noticed that change in delta waves preceded the change in behavior. We didn't know it as we were doing the study, of course, but after the analysis was complete, we noticed that first, there is electrophysiological change, at least in our trial, right, with 30 participants. I don't want to overstate the case, but it is what we found. So first, there is a drop in the intensity of delta waves by about day 14. And then in a couple of weeks after, parents become really excited and report changes in behavior. Now I want to talk about therapies, because also it coincides nicely with the presentation right before me. Therapists had no idea about this trial. We asked the parents, please, for the purpose of the study, do not tell the parents, the therapists, that your child is enrolled in a study. Just don't do it. And about week 7, close to the end of the participation in the study, obviously for active and for placebo conditions, we asked parents for the permission to contact the therapist. And we called the therapist and we asked, did you see any changes in Anthony or in Camilo and Kira for the last 2 months? And the therapist said overwhelming response was the same: better eye contact and better focus, better responsiveness. Now these kids are no longer running around banging their head, for those who did, and they're not withdrawn, not looking at the therapist. They're there and they're willing to learn, they're able to focus, and they can interact. So I really think that this brain stimulation and brain modulation can reach its maximum potential in synergy with the therapy. Because for the therapeutic techniques to work, you need a child who is able to respond and receive. And this is what we want to give the therapist. I just want to mention that delta waves, we didn't come up with it. They have been identified as a possible biomarker of autism before us by other researchers. Again, delta waves are usually present during sleep, and they are called slow wave sleep. However, in wakeful state, they can be present if there is some neurological abnormality, specific microglial activation, inflammation, and they also are present in classical mitochondrial disease and autism spectrum disorder. For example, they have been found in Rett disorder, which is a type of autism spectrum disorder. So this is very consistent with the literature, and we found it in our randomized clinical trial, which is, I think it's great. We had a lot of happy parents. I could be reading these testimonies. I just want to say, instead of reading these testimonies, I just want to say that we had several kids who were relabeled by their therapists spontaneously. Again, the therapists didn't know the kids are participating in the trial. They relabeled the kids from severe to moderate and transferred them to the next group. So we had a 5-year-old girl who was severely autistic. By the end of the trial, her teachers in school convened and decided to transfer her to moderate group. We followed up with the mother. She continues 2 months later. She continues to study in the group for moderate kids, and she's doing really well. We had 2 identical twins, and one happened to be in a control condition and one happened to be in active condition. And that was actually heartbreaking for the parents who were bringing them both and who really wanted to help both of their children. But the child in the active condition progressed. The teachers were gushing about him because he started signaling that he wants to use the bathroom. He turned 6 during the trial, and so did his twin brother. He started communicating his needs. Bathroom wasn't the only need that he was communicating, but he started communicating through individual words, through signaling. He became more interactive, and that was a huge change in his life and life of his parents and in life of his teachers. Unfortunately, that didn't happen to his identical brother who was in placebo condition. So where are we now? We just submitted for breakthrough medical device designation based on this data. We also just received yesterday a patent for the design of our device. And so we want to move on to phase 2 clinical trial. We want to test more kids. We want to expand the age of the kids up to 12 years old. Yes, we love neuroplasticity, but we believe we can expand this window. We want to prove that our device works best in synergy with ABA, and we want to do this comparison between kids who receive and do not receive ABA. We only used CARS for measurement. We want to use very specific measurement. We want to use it language outcome, at cognitive abilities, executive functions, and we want to look at various biomarkers. Most importantly, in our new version of the device, we want to collect EEG in real time with transcranial photobiomodulation to see exactly what's happening in the brain as light comes in. And we want to match behavioral outcomes with EEG data in much more specific and detailed level. And of course, the future is personalization of this device. For every child is different. Every child has her own or their own developmental trajectory, their own story, and we want to be able to make this available and effective for every child. I just want to say a huge thank you to our team. We have an amazing team of colleagues, scientific advisors who are leading us. And I want to say huge thank you to Brain Foundation for inviting us to present. It's truly an amazing privilege to be a part of this group. This is just reference.
Thank you very much, Dr. Steingold. That was remarkable, and congratulations for the placebo-controlled study, which this field really needs to start getting that into the mainstream thinking, right? So there are several questions here, and I'm mindful of the time as well. One, if I could just start, is what is the patient allowed to do when wearing this device? Can they sleep, for example?
They could sleep, but they had to wear the device only for 5 to 6 minutes. So they didn't need to sleep. In fact, this is designed to be a mobile device. So the kids could move around, and that's what they did. They played, they moved around.
Okay, great. And then this one, I'm sure several people had this question, but are TMS and TPBM potentially synergistic, and would responders, should they respond to both? And would there be any advantage?
Fascinating question. The honest answer data will tell. Maybe Dr. Fratkin could say more whether they could be used in synergy. There is not the honest answer. There is not enough data to tell you, precisely.
Okay. Sorry, go ahead, Dr. Fradkin.
Yeah, we know about different studies about TMS right now, but we don't have enough data on photobiomodulation yet. So, but we think that it will have similar results in the future, and we will going to prove it at some point.
Great, thank you. And then the last question I have on the, oh, sorry, maybe it's not the last question. Are there any specific behavior issues that correlate more with delta wave abnormalities, such as scripting, attention problems, shimming, etc.?
So I think it's a fascinating question, and we have to mine data for more for this information. We have this data. We just finished the trials. We didn't look at that level of specificity yet, but I have to tell you, I think attention is because, again, there was something that all therapists reported to us, that kids became more focused. And I do think, and this is just my intuition, I have to do correlations, that the drop in delta wave and the increase in focus go together. That's just my answer today. I have to look at the data. If it changes, I'll let you know.
Sure, fair enough. It's early days, right? And the device is not available yet. Is that correct?
It's not available yet. It's been investigated. We're starting phase 2 clinical trial. As soon as we can, we'll start phase 2 clinical trial, and we can't wait to make it available. Actually, we see dire need. Yeah.
Okay. And so you mentioned the phase 2 or the phase 2 study design changes, and you're going to include sort of with and without ABA. Is that correct?
Yes, we are going to look at this condition separately because we believe it works best in synergy. So we need to prove it.
So you also mentioned at the very end that everybody has their own trajectory, which from a statistical point of view could equal high variability. And so does that trial become very large now in order for you to see a significant difference between ABA and no ABA?
We will have to speak to FDA about the sample size. But I was very surprised with the power of our 30 participant study and the effect size. So yes, there will be variability. I see that there is variability, especially because this is pediatric population. Whenever you work with a pediatric population that is developing brain, there is a lot of variability. But at the same time, I'm convinced now that this treatment is doing something quite powerful. So I think we will be able to overcome the variability.
Okay. Fair enough. So I know we're kind of just about out of time here, and Pramila's online now again, or on video. So I should probably close it there. There's still a couple of outstanding questions, Dr. Steingold. If you wouldn't mind looking at them in the Q&A box and maybe onto those, that would be great. And again, thank you to you and to all the speakers in this session today. Remarkable diversity of efforts here, which is just really inspiring. So bright future, no pun intended.
Thank you.